assigned spot, and you just start rotating around. And be 1 minute, either 1 minute to rest, or 1 minute to look at something and write down, chapter write down, and then you time, everybody moves on to the next one. Okay, so that piece is done within 36 minutes. It's pretty incredible. You will not be able to get into the lab on Tuesday morning starting, first thing, 8, but then you won't be there because you'll be here taking that online exam. So the practical will be set up during that time, and those doors will be locked, and you won't be allowed to get in there even after you finish. If you finish your test early, and I think you will, you'll have time to kind of review stuff. What happened last year, I thought, was people take the test and it might spur, I need to look at this, or I need to think about this again, which allows you at least, an hour or so to get ready to do that before you go to the next part. So I just kind of want you to mentally know kind of what the day is going to look like. If you're like me, I like to know what's coming, and then that way I can kind of get zoned into the whole deal. So 8 to 9:30 here, and then 11 to 11:36, or whenever they start the clock running, in the other room you'll be done. This will be electronic. The grades will probably be released that day, and then the written is hand graded later in that day. It may get posted by the end of the day. That's the goal. It may not, just depends. It takes a little bit more time to look at it. And when you're writing stuff out, people write variations on things like, okay, what am I going to do with that, type thing. So that's how it will be done, and then all those grades will get released as soon as we know them, and you will be getting emails from the exam solve people saying, voila, something's coming, or if they don't, I'll send you an email saying stuff's been released. Yes.
I never received that email from that practice test that you...
It's because what I did is I flagged a button that said don't send electronic emails out. I sent the email, and about 90% of the time I shut that down because you end up with just all this pollution coming out there. And I sent, word pollution, I send out the email that I want that's as soon as that test is posted, the email that I sent to all of y'all about that practice test, that's the way it usually happens. Once it's posted, I send out a note, or someone will send out a note that looks verbatim like that, just goes on with the changes in time and date and what concentrations and what the content is on that test. So it didn't, you're right, it didn't come out because I intentionally said don't send it because I'm sending you something already. But when you get your scores reported, it does kind of pop up and say, something's in your box. I don't quite know what it looks like with Exemplify because I haven't seen one yet, but if somebody will show me one, I'll know what it looks like, but it comes out. But I usually send a note too saying, we just posted the grades, so you can go back into Exam Salt and it will let you see. So that's kind of the way it will go on Monday, and you've been told what you're going to have covered, so that piece you'll be okay with as well. So you still don't have all your content yet. You'll get some more content today, and you'll get some more content on Friday, and then you'll have your content. Okay? Y'all doing okay so far? All right. Are y'all nervous?
Yeah.
I mean, that, I feel it. This is, I will say it's normal, but even if normal is anxious, it is what it is until you've done one. And if you're like most good students, you're not going to relax about this class to see how they ask the test. Because sometimes there's weird test givers and you don't know what you're doing. And you just kind of have to see to get the flow with it all. You'll be okay. The other thing I gave you, I thought y'all had this, I really did, because I missed orientation and wasn't in here, I didn't want to keep repeating stuff that usually is given out to the students, and I did not know if it had been handed out or not. And I got an email from one of the members of the class wanting verification for spring break. And Amber had sent around dates, earlier, but not this whole big thing about how stuff lays out. So I apologize if you did not have this. I really didn't know that you didn't have it. So I wanted you to have it so you can kind of look at how things are laid out. We went over the flow of classes, but you did not get timing of stuff or other ways the holidays work. So let me just run through it real fast, and then I will be done. And Dr. will test if you take control. Okay. Take charge. Okay, it's all been identified. Okay, but you'll see here, you've got Intro to Human Form. It's a pretty long class, lasts all the way down to week 7, and that last week is a History of Physical week, as we've already kind of talked about, just in terms of content presentation. Week 8 is Nutrition. Dr. Latassi will do that. And let me just point one more thing out. Almost always, when a course ends on this week, Friday is February 16th, the last exam is going to end up being the first day of this next class week, so it will be probably in the morning on February the 19th. And then in the afternoon, you start orientation and move into another class. So it's pretty much big wind-up, blowout test. You get to eat, rest, run around, and then it just keeps going. So you'll start that class, it'll run through for a week, and then your test will be on February the 26th, but then you'll start doing the class head, eyes, ears, nose, oral cavity, throat, and it goes on down through there. Your spring break is March 19th through March 23rd. It is not the same as Oklahoma City University spring break, or maybe it'll pair up with some institutions, but not others. We have moved off the Oklahoma City University calendar because we had some other things that faculty had to attend. It just didn't make sense for the curriculum, and it doesn't lay down as well. We don't want to split classes or mess things up, so it's actually better to get these out of the way, and then you have the pulmonology, cardiology block at the end. It is very likely, and it's almost a guarantee, you'll have a test when you come back from spring break, because your heme genetics is going to run all the way to that Friday, and there is just, it is merciless to jam a whole new class of content and take a test on Friday afternoon. You just get killed. So we always move them out. Yes, it does impact the break some, but most students prefer that. You can have your fun, but then figure out your studying at the end, kind of gear back up on that weekend for that test. So just so you know how to do stuff. Don't go to Bermuda on Friday. Don't buy a plane ticket on 1 p.m. on Friday and think you're not going to miss stuff, because you very likely will. And don't book a ticket to get back at 8 a.m. on Monday, because you'll be behind. So just think ahead. If you get yourself in some kind of situation where you just know that you're not going to be here Monday at 8 a.m. for whatever reason, if you're voluntarily planning it, it won't be favorable. I mean, just for pleasure, whatever. But there are things that can come up we need to know. We'll work with you, but you have to let us know stuff. Don't come up on Friday before you go and say, oh, by the way, I will not be here on Monday. That's going to land like a ton of bricks, because it's just very, it doesn't respect timing of things. You can't work with it as easily. I can work with anything far in advance. It's very hard to work with it fair to everybody else in the last minute. And I know y'all know that. Pulmonology, cardiology is the last half spring. The one thing you need to know about this, and we haven't quite got it worked out yet, pulmonology has Good Friday in the middle of it, so on that Friday at noon, this university shuts down, and our classes will end at noon as well. But pulmonology will go this next week. Pulmonology will probably go up until the midpoint of this week of April the 9th. This class, cardiology needs 3.5 weeks, pulmonology needs about 2.5. There's just no way to break it right. So I've got the bulk of the classes where they belong, and when we figure out how things will lay down and where you will get tested, we will let you know. It's in negotiation right now, what's the best way to lay it down and work with outside providers and make it make sense. So that's that. Then you move into the summer, gastroenterology, and you've got your, you've got all your faculty members, coordinators listed out there. First day is May 7th, so it's really, you end one semester and start the next. There really is very little break between semesters, there's none. You'll move all the way up to do gastrointestinal 3, urinary system. There is Monday off, there's no classes on that Monday, so I mean you have a 3-day weekend on that one. Then you go into neurology. Neurology and urinary system probably are going to be similar to pulmonary cardiology. Urinary is probably going to be 2 weeks and a little bit into this one, and then neurology is probably going to be 2 weeks in the last half of that, because those are 2 classes that don't break quite on the week block. Then you'll have psychiatry, and in the middle of that, you'll have July 4th. You're just going to have a day. will be in class Monday, Tuesday, not in class on Wednesday, then we'll be there Thursday and Friday. It's unfortunate, it's nice. If it were on a Tuesday, I'd look at trying to give you a longer weekend, but it's impractical. You cannot chunk 2 days at that part of the program, make it run. So we couldn't do it this time. The musculoskeletal final day of the class for the summer semester is July 27th, and then it picks up again. Dr. Latassi picks up the endo, and it runs on through OBGYN. Labor Day is near the end, so you get Labor Day holiday off. That Monday is not here. Then derm, and then we have a thing called H&P week, which kind of wraps up everything that you've been doing. And there will be activities, working with SPs and all of that. Don't worry about it now. It'll show up at a later date. We'll deal with that. And then you finish up with special populations, pediatrics, geriatrics, infectious disease, across the board, emergency medicine. You'll have a Thanksgiving holiday in the middle of this one. It'll be 20, 21, 22, and 23, so that Wednesday, Thursday, and Friday. Then you're back, and then capstone comes all the way down. Last day of class is December 21st. It is possible, don't make plans on me right now, but it is possible that capstone is going to finish up before the 21st. I actually try to do that, but right now, there is just no way to know how it's all going to lay down. But if I can get y'all out of here, that 21st is on a Friday. If I can get you out of here either on a Wednesday, it will be nice, just to try to buy some time around that. So you can be hopeful with me, and then we'll just see how it plays out. But don't buy a plane ticket and say, oh, I'm going to have to be gone on the 20th. That could be lethal, because the end of that class is there are OSCEs, there are things you have to do, and it just simply cannot be made up. So you have to just play the ball game up to the 21st. As soon as I know something different, I would let you know, okay? But right now, I just don't know it. So that's it, and I hope that is helpful for you all. And I apologize, I really do. I thought y'all had this. Yeah.
On the weeks between semesters, do we still have the test next Monday? So are our semesters pretty arbitrary?
They are our semesters. They do fit the university pretty tight, but what we do on those is the exams do roll over to the next day. So the pattern for these classes is you run the week and then you take the test on a Monday, which you kind of need because you just get so much freaking content, it's almost impossible to do it. If we did do testing on a Friday at the end, then we would probably not have you in class on a Thursday. We would have to, Wednesday afternoon, but we'd do something to kind of give you that shutdown part if we could do that. So, no. And then we have deals with them about when final grades go in. So we do it. So that's a good question.
Think of it this way, where those breaks lie is university driven, and it's also your tuition. So we just run, they break it off and say, these courses are in this semester, these are in this, and these are in this, and this is how you pay tuition.
Yeah, deal. Any other questions about this? Hope this is helpful. Look at this, and I'm going to implore you, if you know of anything coming up where you aren't sure how you need to manage your time, please let me know. And I will work with you, I will advocate for you, I'll do a lot of things, I understand life. But you have to work with us for enough. The deeper you take me, the harder it is for me to make a deal that makes sense for you, okay? And yeah, it's a bad year because it's just bad in terms of flexibility and freedom because it just is like a freight train. It just goes. So you have to kind of pace yourselves and just keep rolling.
I told you it was about that, it's like that maglev train in China.
Oh, yes.
Just how fast it is.
It's that and then some. All right, let me get out of here. Let me get off the system. I need to sign out before Dr. Latassi does something bad under my name. No, it's still, just go back in there. I'm signing for you. Okay.
The other thing I reminded you, I told you in the beginning, is treat it like work. It's training for work. You would never book a flight and not check it with your employer. Okay? Same thing here. So use the same courtesy as you would there. The other is that if you're getting into trouble in something, it's better to let things know earlier. The earlier you identify something, it's always easier. Arrears never works well. It's always difficult to undo something, always easier to do something ahead.
I have a quick question about the holiday break. As far as transition from didactic into clinical, is it safe to assume that until the first, we will not be in clinicals, and then from the first on, it's varying?
The way you need to look at it is you can make your life plan up through December 31st. You have to plan to be here on the 1st because if you're in emergency medicine, in some rotations, they're in business on that day. So until you know what your rotation schedule is, you can't assume that, well, it's just New Year's Day like everybody else. For a number, it will be, but for others, it won't be.
Is that yours?
It's not mine. No. Was that, where'd you pull that?
It was, I pulled it out of the USB.
That's not mine.
Okay.
The other thing I'm gonna ask you to do, and this is harder to do, but I think you need to think about doing it. When you begin to get stressed and spazzed or stretched some way, where it's personal involvement, okay, there's something at home, there is a parent who's had an illness, you are being tugged in one way or another, you have a spousal issue, a child issue, stuff does come up, you're gonna have to be able to self-assess, I'm in trouble. Okay, you will know when you feel stressed and pulled, but you won't know what you need to do with that, and you'll try to self-manage longer than you should. It is better to let us know, you come talk to me, it's confidential behind closed doors, I'm not going out and carrying on about stuff. But if we know that, it makes it easier to figure out how to manage your affairs in a time in a way that maintains your privacy and confidentiality. But what I have usually noticed is that people will know they're stressed, but they will go longer than they should go because they want to look like they can handle stuff. Okay, there is a limit on what you can handle. And maybe you have to just discover what that is, here. And we're not trying to do that, but stuff can happen where you get in a double bind. Please come and just talk about how to manage stuff. There are ways to create some space sometimes that you won't know about. So don't try to solve the problem by yourself when you feel like I'm in trouble now and I'm gonna go down. Okay, or I could. You feel at risk. Don't hold at risk alone. Okay, that's it. See you later.
Thank you.
Okay.
All right, I'm going to start with today's material. If we get done and we can go back and pick up those other two practice sessions that I had, we will. If we don't, we will get it when you look at the PowerPoint. So that's my plan for today. Okay, questions or any issues that you need to bring up regarding my stuff? Did you anybody go back on Quizlet and check the changes? Okay, I think I just opened it before I finished it and moved on to something else, so, because there was multiple ones. I was like, how did I do that? But I think I just let it be visible and didn't finish. Anything else? Other issues? Yes?
Are your exams on ExamSoft as well?
No, my exams, if you go back and look at the syllabus I gave you the first day, no, you've had a lot of stuff. So to repeat, is that it is fill in the blank. I will lay out, you will be out of the room, I'll lay out the testing room. You'll come in, you'll sit down, you'll have an assigned seat, and you will have pen and paper, okay? It's 50 fill in the blank, short answer, I grade it by hand. Okay. Questions? Very similar, what I posted on D2L is what it will look like. Okay, so look at that practice test, it'll give you an idea of format, then you won't be surprised. Most of the questions in Quizlet reflect how I would word it, are very similar. Not all the formats are on there, I'll add some as we go along. Anything else? Anybody not able to get on Quizlet? Okay, let me come back to you.
Scroll down syllabus too, so I apologize. Do the grades get emailed to us or do you post them on D2L? Or I guess it's kind of just a grade till we pass?
I only grade it to 80%. I never tell you what you got unless you fail it. Then I'll bring you in and I'll show you and we'll go over and we'll try and figure out where you're having trouble. So I will email the class and say if you're receiving this email, it'll be and then you have successfully completed. If you did not pass, I email you directly. Thank you. Jen?
As of right now, I still can't use the Quizlet unlock.
Then you're gonna have to request.
Okay.
So I don't know why some people are able to get in with that and some have to request. So just send me a request for the class and I will accept you and then you'll be in.
Okay.
Anything else? Okay, so today we are going to look at, if you flip through, you'll see it's directional terms, anatomic planes, positioning. I saw that on the anatomy course that you all have, somebody's developed Quizlets that go with that. I did not go through there. There shouldn't be any discrepancy. I don't know if Dr. McNeil tests you on those as well. But if you see a discrepancy in the definitions, then just email me. I'll resolve it with him. Shouldn't be, but when I saw that, I thought, well, always. Usually when I'm talking to you in pharm, when we get to the therapy part of disease, usually I'm the last person. So I will bring together what you talked about. And then we're going to talk about, well, then how do we choose a drug? I will usually ask you, is there a discrepancy between what you heard at ClinMed and what I'm going to tell you? I will always tell you evidence-based. ClinMed will usually do the same, but they will also tell you a lot about how they do things. How they do things and how I teach you may differ, and that's okay, that's not uncommon. Usually with the course coordinator, I will work that out is that I usually do all the pharm questions. Not always, but most of the time. So they're not going to come off ClinMed so much, they'll come off the pharm. The reason I tell you that is not that it's always bring up, okay, this person said this person said that. In context, they can both be correct. They can be opinions, not so much fact-based or evidence-based. They may be in areas of gray. So always raise that. You will never hurt my feelings or make me mad to bring those things up, never. Also, to point out my mistakes never makes me mad at you. I may get mad at myself, but I'm not going to get angry with you. There's too much stuff that flies by you. My pace is about the same as your pace. Okay? To do a handout usually is about 20 to 30 hours for me. So my back time on the stuff that I give you is heavy. So I may get behind and be right at the brink where you are. So I'll make errors, I know that. So I have no problems in pointing it out. Do not be afraid of me for that. I will not get angry with you. I would prefer you do that because somebody's going to sit there and go, I don't know how to resolve this, but I'm not going to bring it up. Always bring it up. Okay, so did you all talk about anatomic position?
Yes.
All right. So it is a reference. Anytime you are looking at a description of a diagnostic imaging or you're seeing a diagnostic image, you always assume that that is the position the person was in. Or if you're reading through a note, it's the same thing. Okay? It just gives us all a reference that we can then base off and we don't have to keep going back and going, now, well, how was that person laying? What side was that? It's our basis, it's our foundation, so it's important to understand it. So you see the person standing there in an anatomic position. So that's the one we're going to refer back to. Okay, let me go back to the suffixes. To add AD, it means towards. So when we talk about caudal, we're talking about towards the tail. So that's an example of a word using that. You'll see it in another table. Here's the pertaining to. There are lots of pertaining to suffixes. So if you think about superior, pertaining to that which is above. So here's another one. Lots of them. A lot of it will go to the part of speech or the normal speech that we use and incorporate those. Okay. Well, let's just go back to this. So in terms of, okay, can you see that mouse? Did they fix it?
Yeah.
Yes, okay. So in terms of anatomic position, stance is neutral, palms are face up, face forwarding, feet side by side, person standing erect, arms up at sides. Okay, so let's look at that first table. This will actually, these next couple of pictures will cover a couple of these tables. So you've got a shark, he's going away from you. I have a reason for him being there. Have a horse and have a person, okay, different views. So this is the lateral view of this person. When we're using terms like cauded, it means towards the tail. Cranial, they've used in this position, but that's cephalic or cephalad are other terms that mean the same. You'll see people use them differently, or in the place of. Lateral or side view. And then you've got superior, ascending towards the head, inferior. So the head is superior to the chest. The feet are inferior to the knee. Okay. I put the animals there as probably, I was thinking, why do I always do this? But it's probably my zoo background. I find it easier for some of these terms to think about an animal instead of a human, because we stand upright, they are usually on their belly. So caudal to me is easy for the caudal fin. If you're a fisherman or if you've had zoology, then that's what we call it. So that's what I always remember, caudal's the tail, because our tail comes in the middle of our body. I also remember dorsal fin. So the dorsal fin's on the back, because I don't always think that makes as good a sense as well. So posterior, it's not your butt, it's the back end of the side of the person. Dorsal, also the back. Anterior, the ventral, the belly. Again, belly of the horse, belly of the fish. So if that helps, great. If it doesn't matter to you, then don't worry about it. It's just something else I threw in there to look at. So where do these come important? Where are you going to run into these terms? Pardon? Anatomy, diagnostic imaging, okay? So when you get an x-ray, you want to know what was the view, how did they shoot it, or if you are going to order it, you're going to want to know. So if you've got a lateral view of the chest, then you know they have shot it from the side. If you order a chest x-ray, you're going to have to tell them, do you want it shot anterior to posterior or posterior to anterior? So do you want an AP view or do you want a PA view? Okay. So it will matter when you order, and it will matter when you look at something and look at the interpretation. You want to know, okay, how those x-rays go through those tissues so I can figure out what I'm looking at. So that's why they're important. Let's see. Let's go to the next one. So let's look at this man. So again, right and left are important. So usually right and left, when I'm looking at you, when I'm looking at Kathleen, right? And that's her right, that's her left. It's my opposite, okay? So we're going to use those same terms. When you check out to your preceptors, you've seen somebody, you've examined them, you come out and you check out to them, you're going to use these terms to describe where you saw something. And we're going to use these standard positions in order to do that. So proximal and distal, very common. So proximal, closer to the body or closer to the point of attachment, I think your chart says. Distal, furthest away. Easy to remember, distance. So the wrist is distal to the elbow. Elbow is distal to the shoulder. The elbow is proximal to the wrist. Okay, so you're going to use those terms when you're trying to describe to somebody who's not seeing it. You're trying to paint a visual picture for them where something is. Median lateral. Medial, easy. Midline. So the closer it is to midline, it's medial to this. It's lateral to this. You will use it describing like a lesion or where the pain is that a person is complaining about. In that first, on page 2, that first set, going back and picking up, bilateral means both sides. So if we say somebody has bilateral lower extremity edema, what have I told you? Bilateral, I've told you what?
Both sides.
Both sides, and I've told you it's lower extremity, so where's that? Legs. Okay, and then I've told you the state, which is the edema. Unilateral, one side, so if I tell you they've got unilateral right lower extremity swelling, what have I told you?
one side, right side.
lower leg, and I've told you it's swollen. So that would be a clot will often present like that as a unilateral. Mediolateral pertaining to mid to side. Let's see. Superior, superior, we talked about that. Okay, so go to the next page, there's a quiz. Very similar to what it would look like on your test. Okay, so write those down and we'll go through them. She's in the anatomic position.
Oh, crap.
Always bring something to write.
Mind if I borrow that one? Mind if I borrow that one?
Zach,
Yes,
give me
oh,
some.
I do. Thank you.
Are we describing what the arrows are pointing to, or the direction of the
The
arrows?
direction of the arrows is what you are looking at.
Okay.
Are there repeats in words?
Nope. Do the best you can, it's just, there's no stake here. You can look back at your charts, I don't. Sorry about that.
Did you get these? Oh, sweet stuff. Still a movie. I think for proximal.
Are we doing both quizzes?
Just do the, well, yeah, you can do the next one, that's fine.
It's hard to look at.
If you get finished.
Yeah.
Oh, I guess so. I'm sure there's a
I'll bring it at work.
need more time? Everybody done? Okay. Number 1, what is that? Right.
Right.
What's number 2?
Left.
Okay. 3?
Distal.
Distal. 4?
Proximal.
5?
Superior.
6?
Inferior.
7?
Lateral.
8?
Medial.
Very good. There you go.
Mine says up at the house.
Superior, inferior, how do you distinguish between caudal and cephalic or superior and inferior on that?
You know, you need
No, my favorite pen.
and you disrupted my class to get your favorite pen?
He's such a dolphin.
You know, I could see that. It wouldn't bother me if you did that. Yes, that's where you just valid, yes. Cranial. Okay, let's do this one. Number 1.
Ventral.
Ventral. 2.
Anterior.
Okay, 3.
Dorsal.
4.
Posterior.
Okay. The 2 on the side, 5 and 6, they're not numbered.
Anterior and posterior.
Okay. All right, anterior ventral, posterior dorsal, anterior view, posterior view. Questions about those? Okay, anatomic planes, you've been talking about those. There again, they are imaginary planes that are drawn that help us identify a location, give us a frame of reference. Again, diagnostic imaging often is where these will be used. Chest x-ray, MRIs, CAT scans. Okay. Again, body is assumed to be in the anatomic position. So if you look at your handout, so we've got frontal or coronal plane. So it's going laterally through the body, divides it into 2 halves. Sagittal plane is just a plane that divides the body into 2 parts. So mid-sagittal does what? Right down the middle. Parasagittal does what? It's parallel, it's a sagittal plane, it just divides the body into 2 unequal parts. Okay? And then transverse, forgot that. So it's a cross section. If you're used to doing those in biology or zoology, you take a thing, an object, cut it, and you look at it this way. Cross section. Okay, good. So these are familiar and easy. Here's some examples. So here's a mid-sagittal plane of the brain, equal part, right down the middle. And the MRI tells you that. So I pulled up this MRI, that's the terms it used. Here's another one, another MRI. Here's a parasagittal meningioma. Okay? So you can tell its attachment is off-center. It's right up here. Okay, so an MRI scan of the head, terms they used. So we're not just making you learn stuff. Questions about those? And this shows you the off the middle. Look at what you didn't know this time last week. At Christmas, did you know this stuff? Yeah. Some of it? Well, then you've wasted your time. Okay. You spent money to do it. Okay. So let's look at this one. Here you go. This is a mid-sagittal again. Here it is at the body. Here you've got a coronal plane or a frontal plane, another scan or imaging, and here you have a transverse. Right, so just another reason to show you how those are used. Okay, so take that quiz, just 3 of them. Everybody got it? Okay, what's number 1?
Transverse.
Number 2,
Coronal.
frontal or frontal, and number 3?
Sagittal.
There you go. Anybody have a question about those?
If you say just sagittal, is it assumed to be mid?
I don't see people using it. Sagittal is just telling you it divides the body into 2. It's going to use a mid-sagittal or parasagittal. Okay, body position. So let's look at these. Have you used these in anatomy? So these can be positions that we use to, a nurse may describe how the patient is in the bed, or it may be in order, or it may be blood pressure measurement-wise, we want to know. So when we take blood pressure, we want to know, is somebody laying down, are they sitting up, are they standing? Heart rate can be the same. So that's where these would come into position. Or they can be used therapeutically, like with the orthopnec or orthopnea. So supine, they're laying on their back, facing upward, prone, laying on their abdomen, facing downward. What kind of bike is that?
Recumbent.
It's a recumbent bike. So they're laying down in any position, recumbent. Trendelenburg and reverse Trendelenburg, you see these a lot. So these were developed, originally Trendelenburg was developed for surgery. It was by a German surgeon. And he did it so that he could see the organs better, using gravity to pull them a certain way. So for abdominal surgery, that seemed to help. So in Trendelenburg, you've got the head is about 15 to 30 degrees lower than the body. You might see in ICU, if someone becomes hypotensive, sometimes they'll put them in a Trendelenburg to try to keep perfusion. Reverse Trendelenburg, again, surgery will tend to, could use this. Your head, again, is about 15 to 30 degrees elevated. Common terms that are used. Then the Fowler position, if you look on the next page, you'll see, whoops. Oh, I didn't put it in here. So Fowler position, there's several different types, Fowler, semi-Fowler, and high Fowler. So if you look at it, is mostly dependent on the degree to which the head is raised. So you see is typically, if you go into somebody's hospital room, how are they usually positioned?
Fowler.
Heads up. Usually, it's rare that they are laying flat on their back, right? So they're usually in one of these Fowler positions. So with the head elevated, helps with eating, just breathing, access to the patient. Knees may be elevated or not elevated. Okay, so that's Fowler.
Special practice.
Yeah.
On the packet you gave us, Fowler positions, it says associated with like the knees. So we associate it more with the head or the knees?
It's the head. It's usually the elevation of the head. So what I gave you is Fowler position, so semi-sitting, I'm giving you more detail right now.
Okay.
Lithotomy is more with pelvic surgeries. Whoops. There you go. Knees are elevated and legs are raised, usually in a stirrup. So if they're going to do gynecologic surgery, that might be rectal hemorrhoid, that would be an example. Orthopnea. This I can tell you is the one students miss the most, so pay attention to it. So this is one where if you've got somebody who's, let's say they have heart failure, or they've got a pneumonia, or they are having a lot of respiratory difficulty, this might be a position they would put them in to help facilitate breathing. So you can see with the lady, what they have done is they have seated her up and they have tilted her slightly forward to help with breathing. So orthopnea, what does that term mean? Break it down. I know you haven't given some of the word, but. What does that root mean?
Breathing.
Breathing. What's ortho? Usually refers to position or structure. So it's the position of, we usually talk about it when we have heart failure, because they cannot breathe unless they're sitting up. So we may say they have orthopnea, which means they cannot breathe laying down flat. We have to adjust their position so their heart is higher and their lungs, we've taken some of we're using gravity to help us. So this is how that term breaks down. So sitting erect in a chair or sitting upright in a bed supported by pillows behind the head and the chest, like that lady. It also helps if you've got a big stomach. Let's say you've got somebody who has hepatic failure, ascites, a lot of fluid in the abdomen. That presses up on that diaphragm and they cannot get full breath. So by sitting them up, we use gravity to help us move, kind of move that fluid down some to give their chest muscles and their intercostals a little bit more room to move and draw in a deeper breath. Sims position is in this picture. So if you're looking at, they're laying on, I don't know if the side matters, but I took it on a nursing book, laying on the left side with knees, knee drawn upward, with the left arm drawn behind and parallel to the back. Hers is not behind her back. So another type of position. Questions about those? On the test, I would most likely give you a picture and say, what is this? Okay? So probably this would be the only test where there will be pictures. And you'll have to identify a plane, an anatomic position, just like I'm going through today. Yeah.
How is the picture of the man in the orthopnea different from high Fowlers?
There may not be much difference. It may be more instructional maybe the nurse. Several of these I took out of nursing textbooks. So not as much difference. Wouldn't use that one. I'm going to use one that's clear cut for you all, okay? And those high Fowlers are commonly used in breathing difficulty. I see that used more often than I've seen them drape someone kind of over a table in the room. But that's my N of 1, so it's as good as my experience. Okay, let's take a break. Let's come back at 11 and we'll pick up with the abdominal pelvic regions.
I was like going through and I was looking at it and like, that literally says slogan.
It's mine too.
Have you ever walked me to see my back? It's like you don't care this time.
It does not bother me.
Okay. I was like, I do not mind. If you decide.
I didn't even notice you.
Yeah, I am like that. I'll be like, okay, I'm on that. I just don't want to annoy you for the next 52 weeks.
No, I'm totally good. I'm a good goal.
Yeah, no, like, pretty sure.
Like, I didn't even notice you were bumping.
I bet you could. Besides there. You probably could, right? I mean, I wear made a little bit. Yeah, I wear $7. These are really big on me. And they're like $5 and they go oh, yeah, it's so much yeah. Did I throw it?
What's going on? I got some like rental or like peroxide or whatever for my burn me right here.
That happened to me like a couple weeks ago, and legit, my dad was like, it was like, looked like it was bruised, because it was so like dry and red. My dad was like,
It's not dry though, that's so weird.
really? Mine just,
He's like when you put some.
mine
Yeah.
legit like peeled off, because I had like acne right here, so I was like, oh.
Yeah.
And then, I mean, I'm sure like moisturizer on after, and then just spread it, and yeah, it was legit peeling.
This morning I woke up and I was like, I looked like I had a two brown eyes that were like my It's like just like.
My skin's super dry right now because it's been like winter, and I'm like, I should not go be this dry again right now, because that's simultaneously, like, those should be mutually exclusive. Yeah. There, it's dry again.
And then we go down into two times. The internal external and then internal energy go to the energy area,
That is
go
nice.
to the lungs.
No, mine's like,
And
I'm
then
on my
the
face.
external is to go to the purple area.
Although I tried to.
That's why